I'm going to use Anna Maria's disclaimer about the accent. I'm Italian as well. And as an Italian, I'm going to struggle with less hands than usual today because I got a crutch. But I'll see what I can do. I'm also a clinician. I'm a consultant psychiatrist. I'm working in one of the national services for OCD and BDD. They are part of a highly specialist services network with other colleagues here in the room today. And yeah, I do just a little bit of research on the side. So this talk is about something I feel quite passionate about in terms of offering early intervention in OCD, and how can we do that, in the labyrinth of the NHS system, and what can we do whilst we're waiting? So we're talking about importance of early intervention. I'm going to tell you a bit about the duration of untreated illness and why that matters. Then a bit of what primary and secondary prevention we can put in place in OCD. We'll talk about the step care model in the NHS and how we can navigate it, and what can we do to prepare whilst we're waiting for treatment. So medication, CBT, a bit of lifestyle, and then summary. So the importance of early intervention. So OCD, we know OCD is a common, highly disabling, but treatable early onset condition, and it has been cited among the 6 most common mental disorders, and the top 10 most disabling of all disorders, with 2/3 of the patients suffering very severe impairment. And in US, they estimated that $10 billion per year is spent on treatment for OCD alone, and we've seen the UK study where they're estimating the $2 billion per year. In Spain, OCD has been linked to a poorer quality of life than any other patients group, including those with physical health conditions, with the exception of schizophrenia. Despite this, OCD remains underdiagnosed and undertreated. So OCD is an early onset disease and starts early and has a long duration, with the mean age of onset is usually 9.5 years. And OCD with childhood and adolescent onset is seen in more than half of the patient in a recent international multi-site report. And early onset OCD sometimes has kind of particular characteristics, such as usually there is more kind of genetic, is more frequent in males, and there is a greater severity of symptoms. There's some studies also reported a poorer response to treatment in early onset OCD, but that is not consistent. So what is the duration of untreated illness, and why does it matter? So unfortunately, early onset is all too often not associated with early help seeking and recognition of OCD. And the duration of untreated illness is defined in literature as the latency that there is between the OCD onsets to the first adequate pharmacological treatment. And the DUI has been reported as being 9 to 10 years. So there's 9 to 10 years from the onset of the illness to actually when there is the first proper treatment. And this is one of the highest for any mental disorder, which is quite striking. So why is there a delay? Because we think symptoms are frequently narrowly focused, and then OCD is more likely than other disorders to slip under the clinical radar. Then there's some cultural stigma-related attitude, some types of OCD that might be linked more to shame. For example, OCD with sexual, religious, or aggressive content, so people might be more reluctant to ask for help. Some people believing that OCD symptoms do not represent illness. And then sometimes there are difficulties in detecting the disorder in childhood, because we know children are less able to articulate their obsessional thoughts or to have the maturity to recognize their mental experiences and tell them apart from something that is normal. And it also has been reported there is a poor access to psychiatric services with expertise in the diagnosis and management of the OCD. And also, it has been reported that sometimes patients with OCD avoid medical consultation, for example, for fear of contamination, and that might lead to failure to get appropriate diagnosis and treatment, not only for the OCD, but sometimes also for their medical problems. So in this graph, we see how there is a latency from the onset of OCD symptoms and about 6 years to having the onset of the actual disorder. So there are 6 years where you got symptoms, but those would not be to a degree to fulfill diagnostic criteria. And then you see there's the DUI. So there's about 7 years that pass between when you get actually the diagnosis and when you start seeking for help. And then a further 2 years where people have sought help, but they haven't had an appropriate treatment, which is what is really quite sad. So why does that matter? Because we've seen that it affects a lot of things. First of all, response to treatment with SSRI. So in this study, we see that people with a short duration of untreated illness, so there's the blue columns, against patients with a longer duration of untreated illness, the orange colors, we can see how people with brief DUI respond better to treatment. And the Y boxes, so the rating scale that we use to rate the severity of the OCD, changes more than for the others that have left it a bit too long. So, but not only that, so there's less frequent remission in people with a long DUI. There's a higher degree of family accommodation, which I put that leads to poorer response to CBT, but I've just learned that that is no longer true from Amita. And there is a higher degree of psychiatric and medical comorbidity, lower insight, which again is a predictor of poorer response, and greater severity of OCD in general. And then a long DUI in children and adolescents is reported to be one of the strongest predictors of chronicity of OCD, so it persists more over time. Also, a long DUI might be associated with neurocognitive changes. As we heard for Professor Robbins, so there is an initial goal-aimed response in OCD, and then it becomes more habitual. So the longer we leave it, the more these processes are getting entrenched. Also, there's been an association of long duration of untreated illness with neuroanatomical changes. So, like, actually the brain changes, and we don't want that to happen. We want to intervene as early as possible. And so in this figure from a study from Fontenelle, we see that often OCD starts with symptoms, and the majority, as Professor Feinberg found, do not evolve in full-blown OCD, but some do. And so we got a window of opportunity there to do primary prevention, when you got OCD symptoms, when the symptoms are fluctuating but are not yet of a degree to constitute a diagnosis, and before having a full-blown OCD. So there's been some model that is of staging in OCD that has been created by Fontenelle and Ussel, and the clinical utility of this model is yet to be investigated, and I've kind of simplified it a bit, but you can identify people who are at increased risk, so people that have a family history for OCD, the children of people with OCD that are starting to actually display some OCD symptoms, or children that have family history for OCD and tics, and some environmental risk factors, for example, in the perinasal period, and then the staging gets to the very severe and refractory OCD, which is where we don't want to go. So there could be scope for primary and secondary prevention. So primary primary prevention would be to intervene when you got actually obsessive-compulsive symptoms, but not the diagnosis. And the Australians that are ahead of us have tried that in a study from Vlasios Brakoulias, who actually joined forces with the early intervention service in psychosis, and they tried to pinpoint how many patients had OCD symptoms. And sadly, they found that even doing that, even going out assertively looking for these patients and treating them early, was a bit late because they'd already developed a full-blown OCD. And that is probably because OCD comes even earlier than that. It's not because that was a population of young adults, but we could be doing these things even in children. So psychoeducation and reduction of family accommodation, we heard a lot about this from Amita. It could be interventions that could be offered early on when children are starting to display symptoms rather than just waiting for them to have the disease. And of course, education teachers, doing cognitive behavioral workshops, and even internet-based ERP or some intervention about lifestyles. And secondary prevention is where we come into place as psychiatrists and psychologists, because we're seeing that so there's a 7-year gap before being diagnosed, and then there's 2-year gap before being treated properly. And yeah, that's not good. So we need to, as a specialist in OCD, and I do get a lot of referral for people who haven't had proper treatment despite having lived with the condition for many years. And that's where probably we need to really educate psychiatrists, GP, etc., about how, the doses of treatments, etc. And so first-line treatment for OCD, SSRI, and CBT should be offered as early as possible. And so the theme is important, and I want to highlight this great paper from the International College of Obsessive-Compulsive Spectrum Disorder that published an expert consensus on the need of focusing on early intervention in OCD. So the step care model in the NHS, oh, that's gone different, but anyway, so this is valid for all diseases in the NHS, but we know that it starts like with primary intervention, public organization, the NHS, and then it goes to the GP, the improve access to psychological therapy service, and then to secondary mental health service, then MDT team, so multidisciplinary team with more expertise for the management of OCD. And then we go on to the very highly specialist services. So, in most cases, really, GP can manage a lot of the OCD in terms of prescribing first-line medication, and they're best placed because they know a lot about the family history, the family of the patient, and they have all the medication records, they can engage them, and they can refer him to psychological therapies. And then, but if that doesn't work, it's important to be referred on to more specialized services. And sometimes, when the OCD is very severe and resistant to treatment, also specialist services like ours, so myself, Professor Feinberg, Professor Will, and Amisa, we come into play. But we have our criteria are very strict in terms of, there needs to have been treatments that have been tried, so and also the severity of the OCD needs to be very high. So I don't want to lose my job, but I wish that we get less and less patients, and we shouldn't get to this point, hopefully. In terms of tips on how to navigate the system that we were talking about, is like it's important when going to see the doctor, if you don't, to prepare yourself, and we'll talk a bit later about that, and maybe bring someone with you, and you know, making sure that we highlight the severity of the OCD. So we know that for mild OCD, it's nice guidelines are old, so they're nearly 20 years old now as we speak. So, but we know that mild OCD, they recommend up to 10 hours of CBT with ERP, and then you go with SSRIs or more intensive treatment. Then in severe OCD, they recommend a combination of CBT with ERP and SSRI. All SSRI are more or less the same, and then there's clomipramine, with which you've got more side effect, but marginal superiority. And then if that doesn't work after 12 weeks, and that's really important, that, you know, SSRIs needs to be continued for long enough time, otherwise there's not an appropriate intervention. We delay the appropriate treatment. Then they recommend switching to another SSRI. And if that doesn't work, there is augmentation. They say combine citalopram and clomipramine. We do not do that. And we hope that will change soon in the NICE guidelines. So, yeah, so start with the GP who can refer for CBT with ERP, and you can start discussing the medication. It's really important to express the severity and the impact of your symptoms, clearly. Some areas allow for referral to mental health services, so why not checking that out? And then keep a diary of symptoms, trigger, history to present at the assessment, and you can prepare a list of questions about potential treatment, what to expect from therapy and medication, and how to manage the symptoms. And as I said, you can, you know, bring a family member with you, or if you don't have anyone, then there is advocacy services available in the NHS. If you struggle to navigate the system, there is PALS, which is Patient Advisor Liaison Service, and you know, you're entitled to ask for a second opinion if things, if you don't think things are reflected well in your assessment and your treatment plan. So, but also, apart from that, let's take an active role, and what can we do whilst we're waiting for treatment? We know that the best evidence in OCD is for the combination of CBT with ERP and the medication. We know that from the auto trial that Professor Feinberg conducted. And so it's important to know the key facts about SSRI, and perhaps why not starting them whilst we're waiting for treatment? Because then when you get to the point of having therapy, that works better. And knowing the key facts about CBT with ERP, and actually start doing something by yourself, why not? And then a lifestyle measure as well, support groups that you can access, OCD Action, OCD UK. So in terms of SSRI, the key message I want to leave is like, yes, we do need higher doses in OCD than in depression. So it's important to take the recommended amount. Usually is the highest dose that is tolerated, and is usually the highest on the BNF that works better. Remember, the response to SSRI is slow and gradual, so do not give up. So it takes at least 8 to 12 weeks, not since when you started, but from when you reach the maximum dose to see the actual effect. But then not only, there is incremental improvement over weeks or months and even up to 2 years that has been shown. So don't give up if they don't work soon, because it's normal. And due to the high risk of relapse, duration of pharmacological treatment should be considered long-term in many people, provided there is an acceptable tolerability. Key facts about CBT with ERP: we know that CBT has the stronger evidence for OCD, and we often hear about ERP versus cognitive therapy. I mean, they are the same, and sometimes you got, like in exposure and response prevention, you got more emphasis on behavioral strategies. So you see the as you expose yourself to the anxiety, to the anxious stimuli, the anxiety goes up and then it goes down. And by the time you expose yourself many times over times, then the anxiety drops. And cognitive therapy emphasizes more cognitive strategies and believes that it's not about the intrusive thoughts, it's about the appraisal of the thoughts. And but there is behavioral strategies in cognitive therapy as well, because otherwise it wouldn't work. So there is a lot of doing in that, but they tend to call it more behavioral experiments rather than exposure. And they both include also psychoeducation, development of a hierarchy. So what are the things that you need to expose to and in which kind of order? Homework, relapse prevention, and usually psychoeducation revolves around knowing something about the etiology of OCD, psychological mechanism that maintain the OCD, and then the treatment approach on how CBT strategies will affect this mechanism. So when you stop checking, how does that change the OCD cycle? So what can we do to overcome this barrier to treatment? So, sometimes CBT is not always accessible due to waiting time, shame, and stigma. Sometimes people don't want to talk about it. Costs, if it has to be private, logistical barriers, there's people not going out from their home, sadly. And some, bibliotherapies and digital intervention for OCD have been developed to overcome some of these barriers. And yes, the delivery of CBT with ERP is usually assisted, is usually therapy-driven, but patients can direct their own ERP, and ultimately in CBT, the aim is that the patient becomes their own therapist anyway, so why not start early with that? So bibliotherapy, so it basically is following a treatment manual guiding the patient through CBT with ERP. There's not a lot of studies about whether or not it works, but there's a couple of studies, one on a 6 weeks manualized treatment incorporating ERP and some third wave techniques, showing superiority to waiting list, and also in another randomized control study, but bibliotherapy was found superior. Books we always recommend are Overcoming OCD by Prof. Will, Break Free from OCD, Everything You Need to Know About OCD by Dr. Drummond, who was my predecessor. Digital intervention. So the internet-based therapy has been developed in the past 10 years and has showed superiority to online supported therapy, which would be non-structured CBT, to wait list and to treatment as usual. So maybe people who were already on medication but started having internet-based therapy, they improve more than those that were on medication only. And this has been shown in randomized control trials and meta-analysis. And in some of these studies, there's a sustained effect up to 24 months, which is pretty good. And it's been utilized in routine care in several countries and found to be safe and efficacious. In these treatments, usually there's a protocol, there are modules online, and the modules they unpack as the patient goes through them. And then the role of therapists varies. Sometimes they go support the patient via text messages. Sometimes there are some phone calls, but it's significantly less input than be in a face-to-face intervention. I couldn't find enough evidence yet for the use of apps. But I put down some of the internet-based therapy services that are online. Some of them are free, actually. Exercise in OCD, so lifestyle. We will hear more. We'll hear from Professor Will, so I'll keep this brief. But exercise has been found in a recent meta-analysis has been very helpful in OCD, and there's no a lot of difference between the various types of exercise. Diet, I think I'm going to skip this one because Professor Will is going to tell us all about it later. But yes, in summary, eat well, because that helps. And yeah, we'll hear more later. But in summary, so acting early is vital, and prompt diagnosis and treatment of OCD can dramatically improve life outcomes and reducing the years lost to disability. And shortening the gap between onset and treatment of OCD is possible. And there are pathways in the NHS to support those with OCD, from primary care referrals to more specialized treatment options. But while waiting for treatment, we can reduce the treatment gap with CBT books, medication, digital interventions, support group, and why not, lifestyle changes.
Thank you.